But I made her a presenter, and I'm not sure she'll show up. Can you
All
see
right.
Amy as well?
There she is. Yep. Hi, everybody. We're having a bit of technical difficulties, so bear with us for a minute.
All right. I'm trying to
All right, there.
spotlight the two of us, Amy.
There you are.
Woohoo! Great.
Hello, Dr.
Yay!
Voedisch.
Hi.
Welcome. Hi.
Oh, look, Rebecca and I are both wearing white.
Yes.
We were channeling it today.
Yes. Well, we tend to think alike.
We
As
do.
anyone in this meeting who knows us will know.
Yes, we do tend to be cosmically connected, so it's all good. Great. Well, thanks, you guys. I'm so glad we got this working. Sorry for the drama.
No, that's okay. It's all good. We are 2 minutes past the time, and I'm sure more people will pile in. And I'm just going to start by saying thank you all for attending. This is our second Menopause 201. These sessions are really meant to be educational for physicians, nurse practitioners, PAs, anyone who's sort of interacting with menopausal and perimenopausal women. Our goal is really to sort of dive deep into topics and go a little deeper than, your basic 101 type content. And I want to remind everybody that you're going to get a recording of this afterwards. Feel free to share it widely. I want anyone and everyone who wants this information to have it. And then the last reminder is this is very conversational. Feel free to throw things in the chat. We'll do Q&A at the end. It's just meant to be a conversation. And for this conversation, I am thrilled to introduce Dr. Amy Voedisch. Amy, why don't you tell everybody about yourself who doesn't already know you?
Hi, everybody. I'm so happy to be here today. This is one of my favorite topics. I I have sort of dual backgrounds, which makes this a really fun area for me. I am both a complex family planning expert and a menopause expert, and perimenopause is sort of my sweet spot because both of those things collide sometimes quite spectacularly during this time for our patients. And so this is really kind of my sweet spot for the area of medicine that I'm the most interested in, I would say. So I'm really happy to be here.
Give everyone your credentials. You forgot that part.
Oh, credentials, yes. Yes, I don't know how far back we're going, but I went to medical school at the Mayo Clinic. I did residency at Kaiser Santa Clara. I did a fellowship at Stanford in complex family planning. I then did the Menopause Society certification several years ago. I most recently wrote clinical guidelines from the International Planned Parenthood Federation on their very first statement on menopausal care, which was really exciting. And then Dr. Rebecca Dunsmoor-Su and I have co-written several papers together. One of them is a huge clinical practical guide to menopause that I think has a lot of really nice practical kind of nuts and bolts information in it. And then we are also co-writing a book on menopause together. So stay tuned.
Perimenopause.
Perimenopause together. Oh, goodness.
Yes. Stay
Yes,
tuned.
clearly.
And that one's aimed at the layperson. Yes. And we also are co-authors on an article about testosterone that's made some waves.
Yes. Yes.
And we may or may not get into that part today. I was going to start our conversation. I think one of the most common questions we get in clinic, and probably everybody on this call gets in clinic, is, hey, doc, how do I know where I am in perimenopause? What tests are you going to send on me? And like this, this practitioner I went to go see said, I need to get all these blood tests and that my X is low and my Y is high and all that. How do you approach this with a patient? Because I think, first of all, I would say, why is testing maybe not necessary? But also, how do you explain that to a patient so that they're on board with that? Because they've been told by somebody else that they need this test, or they need to go to the grocery store and buy the Clear Blue Easy damn stick that you can pee on. Sorry for the language.
I think it's tough. A lot of times by the time patients get to me, they're pretty frustrated. They've been, and you see this as well. By the time they get to us, they're frustrated, they've been dismissed. And so when women are frustrated and dismissed, they start going to other sources. And so this is where those sort of med spa, naturopathic places come in, because they're like, oh, we'll listen to you. We're going to, check your hormones. We'll tell you exactly where you're at. And then we can make a plan for you. And that makes them feel heard. And so the
Mhm.
number one thing is to make sure that patients feel heard and validated.
Right.
And so I do spend quite a bit of time on that. And then
Yeah.
the way that I approach it is I will sometimes even show them sort of a graph of sort of what's happening hormonally at this time and say, it's pretty wild. It really depends on the day, the time when you check these. Your hormone levels are constantly in fluctuation, so it's not always super helpful. And so at this point, we don't really have great testing that can predict sort of where you're at or how much longer it's going to take. And hopefully over time, maybe we'll be able to come up with something that would be a better predictor. Um, yeah, I always tell people it's a little bit like being in labor. If you know it's only going to be like 4 minutes, maybe you don't get the epidural. But if it's going to be 36 hours, you want the epidural. So it's a little bit similar with perimenopause. Like, is this going to last forever, or is this going to be over relatively quickly? I need to know how long I can sort of white knuckle this. And so we sort of talk about that. We're not there yet. Maybe we will be, but at this point, those tests aren't super helpful. And so I'd rather do things and talk about strategies and evaluations and different things that can be helpful and are useful at this point with where we're at.
Yeah. So there's a question in the chat that I was just about to respond to, but I'll just answer it out loud. If you go to Up to Date, strangely enough, they have a beautiful graph from Dr. He's paper that was published in like 1990 or 1999. And he basically got several patients to be tested over and over again through a year of perimenopause and marks their menses and everything else. And it shows you like FSH of 2, FSH of 90, FSH of 6. It shows how it's all over the place and correlates it with their menses. So that's a great place to just pull that graph. I have it on my desktop and I show it to
Oh,
patients all the time.
mm-hmm.
I was going to say the other thing, there are some other things that I say to patients when they're asking me about this. I explain why the testing is not helpful. But then the next thing I always say is, and it doesn't matter to me where you are in that process because you're telling me you're symptomatic. And I'm going to treat you if your labs are normal or abnormal. I'm going to treat your symptoms, and that's what I care about. And I'm going to treat you until your symptoms are better. So whether your estrogen is high or low today doesn't matter to me.
Right.
I'm going to go by your symptoms and your most important vital sign in this process, which is your period, because that lets me know a little bit about maybe where you are in that transition. The other thing for my more sort of savvy patients, I sometimes tell them a little bit about, they've looked at lots of different things to predict perimenopause. So we've looked at FSH. It's totally unreliable in the perimenopause.
Right.
It's up 1 month, down the next. We've looked at, so I think there's a paper, has to be 5 or 7 years ago now, from Dr. Santoro and her group, where they looked at AMH. And they found that if you use an AMH test that tests all the way down to picograms, then you can kind of predict within 6 to 12 months when someone's going to go into menopause. I would argue we can do that based on their period, but this might be useful in someone who doesn't have a period for various reasons. But you can't get that test. It's a research test.
Right.
When you do an AMH in any lab that's available to us, it doesn't go down to picograms, so it's still not helpful. So there just is no testing, and I will share the graph in the chat later, I promise.
The other one that I think sometimes is helpful for my patients who have thyroid issues because they're so used to having their thyroid hormones so tightly managed based on their TSH level, and talk about how this is just totally different, that this is a very different thing. We go based on symptoms. And it's really interesting because some patients will say, I wish my thyroid doctor would do that because it says my TSH is great, but I actually don't really feel well, which is kind of an interesting sort of flip side to it, which is not part of this conversation, but is just kind of a different, I was like, it's a different philosophy than they have, maybe your endocrinologist has.
Yeah, no, that's true. And often, I love our endocrinology colleagues, but they really do like to treat to a test. So I see a lot of the testing being done by endocrinology over and over again to try to manage by numbers. And the problem with that is, if you think about the normal range of estradiol in a cycling woman, it's anywhere between 12 and 500.
Right.
And as I tell my patients, I don't know where in that range you're going to feel better. You know,
Right.
an estradiol of 20 is a normal estradiol. An estradiol of 300 is a normal estradiol, but you might feel better at 50. And why would I give you 300 and increase your clot risk if you're going to feel better at 50? Like,
Right.
that's why I don't test. I just dial up the estrogen until you feel better.
So in what scenarios, I think it's helpful for some of
Uh-huh.
some patients to know when would we test? Like when would we
Yeah.
think about doing an an estradiol test? So what do you
So
generally, how do you generally
the
approach
most common time that I have used testing is if I have somebody on hormone therapy, specifically transdermal hormone therapy, and they're not getting symptom relief. And we've tried a couple of dose adjustments and they're just not getting symptom relief. And then what I often do is do it on day 2. So they put their patch on day 1. On day 2, I have them come in and get an estradiol level because then I can make sure that they're actually absorbing the
it? Right.
hormone.
Yep.
And if they're well within a normal range of estrogen, they're getting, they're at 100 or something and they're still getting 0 symptom relief, then we start looking for something else that could be causing their symptoms. But I have had like my favorite patient case. She really wanted to be on estrogen. She was a glass blower. And you can imagine the hot flashes in that career choice pathway. And
That's a,
she tried all the estrogen doses. We had her on like 2.1s at one point. And she just was not getting any symptom relief, even at night, like even when she wasn't blowing glass. And finally, I tested and she was getting nothing because in the process of blowing glass, she sweats so much that she was just basically washing everything away. It wasn't working. Put her on oral, happy as a clam. So there are times when it makes sense to test, right?
yep. I think exactly when you're trying to figure out route, or if you're like, this isn't making clinical sense, like
Mm-hmm.
you should be feeling better. I mean, I've had patients who have, the fem ring, so they have the
Mm-hmm.
vaginal ring, and theoretically, the vagina does a great job of absorbing estrogen, but not necessarily
Mm-hmm.
for everybody. Or different brands of patches with their different adhesives can
Mm-hmm.
sometimes interfere with some patients and not with others. And so changing it up, so that'll be one of the reasons I'll test as well, is if they're, clinically it's not making sense to me, like, well, you
Mm-hmm.
should be doing better, so why aren't you? And then
Right.
we can sort of play around with different routes and see if that works.
Yeah, no, I think that makes perfect sense. And that was a really good point because there are some times when we do need to test.
Yep.
Um, I think the other big topic that takes a lot of explaining when we're talking to patients is when do we go with a birth control pill? And when do we go with hormone replacement therapy? And how do we make that decision? Because it's a little bit of the art of perimenopause rather than purely science to a point.
Absolutely. No, this is definitely the art of it. I feel a little
Yeah.
bit like a chef, not a pastry
Hmm.
chef, because you have to be very specific when you are
Right.
baking. But when you are
Yes.
cooking, you can have a little bit of this and a little bit of that. And so, from a family planning perspective, the number one
Yeah.
question is, um, do they need to be contracepting? So, do they need a contraceptive method?
Right.
If they don't, then we don't necessarily have, it doesn't mean that a hormonal contraceptive isn't an option, but it
Hmm.
just means that's not maybe my go-to, necessarily my first line, depending.
Right.
So then it's a whole combination, but let's say they do. So let's say they do need a contraception, because then we have to sort of think through, how is that going to work? So
Hmm.
for my patients who need contraception, it's all of the options are on the table. Obviously, you have to look to make sure they don't have a medical contraindication, but let's say all the methods are on the table. Um, then I start to look at, what are their other symptoms that they're having? What are the other things that we're trying to control for?
Hmm.
Um, and do we have really, really heavy periods? And so maybe we want to think about something that's going to give us really nice cycle control.
Right.
Something like that. So let's say in that particular case, I would think about an IUD or a combined hormonal contraception. So,
Okay.
um, and the thing that I like to tell, sort of, that I think is really important as a take-home point, is that combined contraceptives can do a really good job of sort of meeting all of the things that a patient might need. And so oftentimes patients will come to us and they're really frustrated because someone has been like, oh, you should be on a birth control pill. And they're
Hmm.
grouchy because they're just like, they ignored me. They just wanted to put me on birth control. That's not what I
Right.
wanted. I want to address my perimenopausal symptoms. So then we sort of dial back and say, okay, what's going on physiologically? Why would this be a reasonable choice? So number one, if you need a contraceptive, great, we're good to go with that checks that box.
Right.
But what's nice about the combined hormonal contraceptives is that they can actually treat a lot of your perimenopausal symptoms. So the irregular bleeding that might be driving you crazy. Sometimes can be helpful for vasomotor symptoms and hot flashes. If you're having a lot of mood symptoms, for some people that can be really helpful. If you're having acne, which, you know, with how fabulous for that to be coming back in our 40s, and we're just like, you gotta be kidding me.
We all love that one.
Yeah, that's great. So maybe you can hit a lot of different symptoms with one treatment modality, which is great. So I love combined hormonal contraceptives. I think they actually can be a super helpful tool in this phase for sure. So that part is really helpful. But the caveat being, just because someone's on a combined hormonal contraceptive doesn't mean they can't have breakthrough perimenopausal symptoms. Because I will see that with my colleagues where they'll say, she's on a birth control pill, she's not having hot flashes for this, they need to go see their primary care doctor. You can still have breakthrough symptoms, and it's because the ethinyl estradiol in birth control pills isn't always as good as plain old estradiol in terms of addressing our perimenopausal symptoms. It might be awesome and it may take care of all of the things, but if somebody is on a birth control pill and they're having breakthrough symptoms, don't dismiss them and send them off to the primary care doctor. You definitely want to sort of think through, do we need to change up the formulation? Do we need to do something totally different? And so you can kind of think about that.
I have a question based on that. So what's your experience? Do you find that people have more or less breakthrough experiences using Nextstellis or estetrol-based pills than ethinyl estradiol?
Oh, I just love Nextstellis.
Me too. That's why I brought it up.
I'm such a huge fan. It's such a fabulous, first of all, the combination with drospirenone and the estetrol, I mean, brilliant. And second of all, estetrol, I love about it, but as a novel sort of new sort of estrogen that we're containing in these birth control pills, I think it's great that we actually have something new to talk about. And I do think that it can be more helpful. It has different affinity for the estrogen receptor than ethinyl estradiol does. And so I think it can be more helpful for the perimenopausal symptoms. The other thing that I love about it, and I'm going to nerd out for a second on the.
Please do.
I'm
this
totally
is your
nerding
audience,
out.
Amy. Nerd out.
I'm nerding out here. So the thing that we worry about with ethinyl estradiol is that it's the first pass metabolism, the impact on the hepatic coagulation factors. The other thing with ethinyl estradiol is that it actually comes through for a second pass hepatic metabolism. So its metabolites are just as active and also continue to impact your coagulation factors. And that's why ethinyl estradiol has such a strong thrombotic impact. Whereas estetrol does not. So its metabolites are not all that active. So they're not going back through the liver to further impact those, our thrombotic risks and our coagulation sort of cascade. So that's why I kind of totally nerd out on it as well, just sort of combining all those things. And people start to worry about, a 48-year-old on birth control, and I'm worried about her clot risk. And it's like, well, this could potentially be something that could be potentially a little bit safer for her, or something to kind of help, soothe our concerns about that.
The other reason I really like it is because it does have different affinity at different types of receptors. So it's much more nuclear receptor activator than a cell wall activator, which means that you get less breast tenderness. And breast tenderness makes women nervous in this time period, understandably. So I find that it can be really helpful to minimize that. And drospirenone, nobody doesn't like drospirenone when you're 48 and gaining weight and having acne. I mean, drospirenone's the bomb. So
yeah, I know. It's so good. And it's been so well studied. So people will worry about, well, has this been studied in the setting of menopausal hormone therapy? So just like with all things in women's health, not everything's been studied in terms of as part of MHT, but drospirenone, we actually have a lot of studies on it. And there's been even doses as low as 1 milligram have been found, in like Slind. I will use Slind, just an only version of drospirenone for menopausal hormone therapy. It's 4 milligrams, so it's a lot maybe higher than we need, but it can be really helpful if you need birth control and you want to do estradiol rather than Nextstellis as a combination. Because one of the issues with Nextstellis is the insurance coverage and,
Yeah.
getting it covered and
Although it's not that much better for Slind, let's be honest.
No, it is not. No, it is not.
We have a question in the chat, which is any inside info on S-tetrol for HRT? And yes, I do have some inside info on that. So they are currently trialing S-tetrol as MHT with the goal to release it basically as Nextstellis for MHT. So they're trialing it at the same dose that they have it in Nextstellis. So interesting fact about how we have to run MHT trials in the US, the FDA requires you to run unopposed estrogen trials for MHT. So they are currently trialing it as S-tetrol only, doing endometrial biopsies to prove once again that if you give estrogen only, that it will cause the endometrium to grow. And then they will package it with drospirenone, probably in the exact same dosage as Nextstellis as an MHT option. So that's another nice thing when you're talking to somebody who's in that perimenopausal phase and say, hey, this is probably what the MHT version of this is going to look like. So you can kind of just keep going.
Right. Right. Which is nice. Right. So you can kind of, that's the big thing is bridging patients, kind of bridging them over. And do you need to make, it's hard sometimes to make changes. And if someone has felt terrible and now they feel good, the last thing they want to do is change to something else.
Yes.
So I have a lot of very interesting, very interesting combinations of things that are happening as we're helping people try to transition. So it's really nice to have an option like that where we can just roll right into it. The other one, just keep going. The other one that I do love, one of my other favorite combos, is the use of the levonorgestrel IUD combined with estradiol in whatever form. It could be vaginal, it could be transdermal, it could be oral, because you get great bleeding control and fabulous bleeding control, and you can add and titrate the estradiol, because one of the things sometimes with the birth control pill is it's sort of one dose. You can kind of go up and down a little bit on the ethinyl estradiol dosing, but Nextstellis is one dose. So if you want to piece those, take those apart so that you get your endometrial protection, but then you can dose adjust your estradiol however the way you want to do it, which is really nice. The caveat with the hormone containing IUDs, at least when I've done a deep dive of the literature, is it really has not been studied past that 5-year mark. And so although it is approved from a contraceptive standpoint for longer, we do not have data on it for longer than 5 years. And so, and I've done like a pretty extensive deep dive looking into the literature. We do have in Europe what they call postmenopausal IUDs that are 10 micrograms of levonorgestrel. The issue is that as the different levels of the levonorgestrel IUDs go throughout their lifetime, the amount of levonorgestrel that they're, emitting or releasing drops below that 10 microgram threshold. And so we just don't really know, is 5 micrograms of intrauterine levonorgestrel enough? Like we don't know yet. And so it's a study I really want to do. But if we want to,
we all do. I've been pushing Bayer to do that study for a long time. They're like, yeah, well, we're not approved for this anyway, so we can't really fund that study. Like, yeah.
No. If only we were billionaires.
Yeah, I know, totally. I was gonna say the one downside of the Mirena plus estradiol, because I love that combination as well for a lot of my patients, because you get the contraception, you get management of bleeding. They can use estradiol, which a lot of women really like. The one problem with that, the one population I don't tend to use it in is my patients with severe PMS or PMDD, because for those patients you must suppress ovulation, because the PMDD gets so bad in perimenopause. Gets so bad. And the reason really is, I like to talk about loop ovulations when explaining PMDD to patients. So I know we both love loop ovulations. So luteal out of phase ovulations are where, you recruit a panel of follicles to sort of come on as eggs, but none of them are good enough. So you're just getting tons of stimulation from the FSH. So you recruit more eggs, but they're on different cycles. So you get a burst of estrogen, and then you get another burst of estrogen, and then you're way up here with estrogen. And then finally one ovulates and you fall off that cliff. And we all know PMDD is the drop in estrogen and progesterone at the end of the cycle. We're falling off a massive cliff in perimenopause.
Yeah.
And so it can be really devastating for patients. So just taking ovulation out of the picture is one of the main reasons why I use OCPs in this time period,
Yep.
even for just anxiety. Like, I think it does a great job at managing perimenopausal anxiety, which is a huge issue. We should talk about that totally separately. But anyone with PMDD, anyone with significant mood symptoms around their period, it's nice to just take ovulation out of the game.
And menstrual migraines are another one.
Oh,
We're
yes.
taking, if you can
Mhm.
take ovulation out of the picture,
Mhm.
so helpful. And so that's a great one. Everyone gets a little bit nervous if it's migraines with aura. And so that's another one where Slind is awesome because you
Yeah.
can take the ovulation out of it. And then you
Yeah.
can add transdermal estrogen if they're
Estradiol,
having
yeah.
other, if they're having
Yes,
other.
because transdermal estradiol is not contraindicated in migraine with aura.
Correct. Yes.
And I'm going to add a little caveat. There are several opinion pieces from leaders in the Headache Association that say that probably it's safer to suppress menstrual migraines with combined OCPs, even in migraine with aura patients, because if you're having fewer migraines, you have a lower stroke risk.
Yes.
That being said, the recommendations haven't changed yet. So that's a
No.
complex conversation.
Yep, it is yes, it's a very
Yeah.
complex conversation, but a lot of my neurology colleagues think that we as gynecologists are way too
Mhm.
strict
Yeah.
with given, yeah. So it's an interesting conversation.
We're a
But
little lawsuit fearing
we're a
as
little concerned.
gynecologists.
Yeah.
So most of my patients will then ask, well, if we're going to start OCPs, when are we going to stop?
Yes. Oh, that's one of my favorite questions. I actually get asked that a lot in terms of how do I know if I'm in menopause if I'm on birth control? Sort of the general thing.
Right.
So number one, I like to look at a lot of the society recommendations are continuing birth control until age 55 or menopause is confirmed. So for those patients who are just doing awesome on their birth control, let's say the regimen they're on is controlling their perimenopausal symptoms, they're contracepting, they feel awesome. There's no need to make any change if you don't want to, unless they have a medical contraindication that comes up where you need to change things up. So number one, you could just leave it till 55. And then at that point, you don't have to worry about contraception and you can transition into, if you want to, into sort of a different formulation. Because if they're on a combined hormonal contraception at that point, then, at age 55, you'll want to consider transitioning to something that's a little bit lower dose. Otherwise, you actually can, it's kind of crazy, but you actually can check for menopausal status. I wrote a paper on this, and so I did kind of an interesting look into the literature. It's soft. It's a little bit soft markers. Number one, it is confusing, and it's hard because you don't have the periods as a marker, and sometimes it can be difficult to check labs to sort of help you. So what I think is interesting is something like Depo-Provera, which we don't often see in perimenopausal women, and it's not my favorite because of the impact on the bones. And at this point, we're losing our bone health is so important. But let's say you have somebody who's on Depo, you actually can check FSH levels on Depo because Depo does not suppress FSH, it suppresses LH, which is kind of interesting. So you want to check it on the first day of the injection. So day one, and then you can do a repeat, sort of a repeat 90 days later. And so if you have two of them where the FSH is elevated, you could tell them, you could tell them to go, that, well, you're probably in menopause. We can most likely transition off of this. For CHCs, you could test. I just saw the question in the chat. You can test during the placebo week. Sometimes you need to take longer off because the FSH is suppressed. And so you may need to take a significant break, but you could check it at the end of the week. And see. I just saw the question about what FSH level equals menopause. So this is interesting. I wrote a review article on this in Current Opinions on PubMed, so feel free to Google that. But when you look at, so for example, with Depo, we would use a level of 30. For some reason, that was what the studies were. It was an FSH of 30. You repeat it 90 days later. If the FSH is still 30, you could say you're considered in menopause. With the combined hormonal contraceptives data, they did a 20 level of greater than 25.
But here's
So
the thing, you can have a level of 25 in perimenopause.
totally agree. Yeah. So
So
what they
so it
yeah,
doesn't tell you if they're fully menopausal, right?
no,
It tells
but
you
they can,
if in this cycle they're menopausal.
yeah. No, I totally agree. And so I think I always tell
Hmm.
patients, if we can always do a trial off and see
Hmm.
how you do. And if the wheels come off the bus, we can get you back on the same, you can get you back in the same. There actually is not a level of FSH where we would say you no longer need to be on on contraception, because the FSH level can fluctuate so much. And so a lot of the studies looked at, like when they came up with these little guidelines, which again are soft markers. We don't have a ton of data on this, but I did write a review article on it. It was, you would then repeat it again. You'd have
Hmm.
multiple ones that showed that it was elevated. And what they said for the IUD was you could check FSH on an IUD, and if it was over 25, then they should continue the IUD for another year, and then they can go off. Then they could go off of their IUD. So, I don't know if it's all that helpful,
Yeah.
to be honest, but if you have someone, for example, you have a patient who's very data driven, or you're trying to
Hmm.
do some shared decision making, I do have a little article on it, on ways that you can use it. But again, you could go off it, and they could,
Right.
periods could start up
I
6
mean,
months later.
we've
And
all had the perimenopausal patient who has 9 months without a period and then throws an egg, right? So,
yep.
and during that 9 months without a period, their FSH is well over 30 for most of
Oh
those
yeah,
months, most likely. So, not a year without a period is really the only solid marker we have.
agreed.
Um, so I have seen FSH over 60 on two tests separated by 90 days as a marker. But even that, like, I mean, most people who are perimenopausal don't get over 90, but that's hard. And actually fully into menopause, often they're not over 90, right? The
Right.
FSH drifts down as we get further into menopause. So
Yep.
most fully menopausal women after a year or two are in the 20s to 30s. So
Yeah, that's kind of where they hang
it's
out.
just not a great test.
It's not helpful. We
Yeah.
keep trying to fit the square
Yeah.
peg in the round hole, and it's just not exactly the way we want to do it.
No, it's not. It just doesn't, like, we just don't have the test yet. I wish we did.
I
I
know,
think there are other
it would be
things we need to
great.
look at, but we don't have
I
the
mean, if
test yet
there's a
for it.
way, that we could
Mm-hmm.
figure out how AMH would work, like if we could get
Mm-hmm.
sensitive,
The
like that
picogram test.
picogram test, because we could do AMH on these
Mm-hmm.
different,
Right.
hormonal
Right.
contraceptives. So that would be really cool.
No, very true.
Mm.
All right. Another topic to talk about is, what does your testosterone do in perimenopause and menopause, Amy?
Oh, well, if you believe the Medi spas, it's doing a massive tank. And so
Yeah, no.
therefore you need to be on, incredible Hulk doses of pellets.
You
It
will
really
feel
doesn't
great.
change. Yeah. It really, the level really doesn't change. There's not a dramatic drop off,
No.
despite, you know, what
Right.
the media would love us to believe and Instagram would love us to believe. So there's not a big change. What I think is sometimes sort of happening when people are like, oh, but my libido, I'm like, well, if you don't feel well, you're not sleeping, you're
Mm-hmm.
anxious, there's weight changes that, happen. People don't feel good about
Mm-hmm.
themselves. They've also been married for 20 years and they're looking at their partner going, oh my God, you're still here. Like it's a lot. There's so
Yeah.
many
And their
factors. But I think
teenage kids are still there and awake until 2 o'clock in the morning. So you don't really feel like going, oh, by the way, Dad and I are going to go have sex over here now.
right. Yeah. No, it's not happening. No, you're just like, no, I'm not doing this. So I
Yeah.
think the big takeaway is just when we look at serum levels, not changing,
Right.
you know,
Well, I think
it,
there's a huge myth in this country that testosterone drives everybody's libido. It
right.
doesn't, it isn't a major driver for women throughout most of their lives. At least, I mean, obviously gross generalization. So take it as what it is. But our libido has always been much more responsive to intimacy and feeling comfortable and good. And so, yes, if we give you enough testosterone, we will make you feel like a 14-year-old boy and want to have sex. But that's not because you were missing it. It's because testosterone has that side effect, right?
Right.
But it always drives me crazy when people come in and they're like, I have acne and chin hairs and I'm going bald, but I need testosterone because I don't want to have sex. I'm like, hello, these are testosterone signs.
Right.
You already have too much that you're reading. Why would we add more?
Nobody needs to add more. So
Yeah.
what do you tell patients who come in because they want it for energy? They want it for muscle mass. They want it, they're like, oh my, I can't lift as much at the
Right.
gym or,
I tell them that cocaine works better. I don't actually say it that way,
right.
but I say that medications have particular uses, but they also have particular risks. And we shouldn't be using things to stimulate energy that might have side effects and or risks that we shouldn't be giving you. This is like, to get better energy and to lift more, you need to eat more protein and sleep better. And these are going to give you long-term health benefit.
Right.
Testosterone's not. And if we use too much, it might even give you a long-term health risk in terms of cardiovascular health and your lipids. So, I do sometimes, in a patient who I have a good rapport with, I will sometimes make the analogy that, hey, if I want to make you feel better, I could give you cocaine. It will make you feel great until it doesn't.
Yep, until it doesn't.
But there are so many risks involved with it, we don't use it that way. And
Right.
this is the same category. But also, like, the side effects of testosterone, if you get high enough, are irreversible. If you
Yes.
lower the timbre of a woman's voice, it doesn't go back up. If you give her full male pattern baldness, she's not getting her hair back. So,
Right.
and often they're not told those side effects. I think the
No.
other thing, which we addressed in the paper, but we should say it again, is that when they've gone to the Medi-Spa and the Medi-Spa sent a free and total testosterone, it was 0. I always have to tell patients that's not because your testosterone is 0. It's because the free and total testosterone test is valid only at male levels. It is not a valid test below 50. I send it if I'm starting testosterone for HSDD. Separate discussion. We're having that discussion later, so come back for another Menopause 201. I send it then to make sure that they're not over into male levels, because some women can have too much, especially people who've been PCOS their whole lives. But I'm not sending it to get their level. I'm sending it to make sure they're not too high before I start extra.
Right.
And then I'll use it again to use that test to check to make sure we're not verging into male range when they're using it. But it's not because it's valid at those low levels. Anything in there is the same because it's just an invalid test.
So you're really just using it for monitoring their serum levels in response to therapy.
Right. Exactly.
Versus, just to make sure it's not getting.
To make sure I'm not giving too much. That's
Yeah.
the whole reason I use that test. If you want to get an accurate female testosterone, you have to send a liquid chromatography, which is a very expensive test and not really indicated because, again, it's not that important. And, if you're going to use it for HSDD, use it for HSDD carefully. And if you're, if they're asking it for any other reason, then counseling is the appropriate course. And I also, I have had patients I had one patient who came to me whose trainer sent her to, a Medi-Spa type place for natural testosterone. So she'd do better in her Ironman. And I said, you do realize you just doped yourself out of that Ironman.
Right.
She's like, no, I'm not doping. I'm using natural testosterone. I'm like, which is a banned anabolic steroid. She's like, no, that's not true. I'm like, yes.
Yes, it is.
Yes, it is. So much fun. I made a list of sort of harder to manage patient scenarios I thought we should touch on. How about patients who've had a blood clot or who have had breast cancer and are having significant symptoms through the perimenopause?
I know those are the hardest ones, right?
Yeah.
Okay, let's start with breast cancer. That's tough. So, that's really hard because in general, if they have a history of breast cancer, we don't recommend, that they are on menopausal hormone therapy.
No.
But that doesn't mean that they're not going to have symptoms.
Right.
And, which is tough. And in particular, when if they're on endocrine therapy, for, recurrence prevention, et cetera, some of their symptoms can be better or worse or whatever. So that is always really hard. And I talk a lot about sort of our non-hormonal options that we have at that point. So Veoza, for the vasomotor symptoms. So we have that. And Veoza's, it's great to have it as an option. I'm excited for newer versions to come out.
Yeah, next year probably.
Yeah, so I'm looking forward to that. I think has been helpful for some people and has been a game changer, but I think we can get maybe a better medication out than
Mm-hmm.
that one. But again, the class of it, I think makes a lot of sense. So if we talk about what's happening with Veoza, why does Veoza work? So
Mm-hmm.
you have your candy neurons in your brain and sort of your, I call it the nest. The way I explain it to patients, like you have a nest. You have your thermostat in your brain, and it's controlled by a combination of estrogen and these candy neurons. And when estrogen isn't around or is kind of fluctuating all over the place, these candy neurons just go bananas and berserk. And so you're just all over the place. And so there's nothing to kind of keep these candy neurons in check. And you may have a better explanation than I do. So I'm like, so I
Yeah.
need to get your nest to be better controlled. So if we can't use estrogen, then we can use something like Veoza, which helps to control those candy neurons so that you're not having these like
Yeah.
crazy surges, heat surges, your own personal
Mm-hmm.
summer, as patients will say.
Yes.
Um,
And
so I
Veosa
will,
has actually got increasing data, although they haven't published it all yet, for some assistance with sleep, probably because of the reduction in night sweats, but it may also help with some of the sleep disturbance.
which is kind of nice, right? Because sometimes patients don't have vasomotor
Right.
symptoms, but they have all the other things. And you're like, oh
Mm-hmm.
gosh, how are we going to help with all of that? So for the breast cancer patients, I'll talk about Veoza. I talk about gabapentin. I talk about to take at night to help with both sleep and vasomotor symptoms. I talk about Brisdale, the
Mm-hmm.
FDA-approved version of Paxil, sort of derivative of Paxil, which sometimes can also be very difficult to get covered by insurance.
I
So
know.
sometimes we just do generic
Excellent.
Paxil.
Yeah.
So we have that as an option. And then there's cognitive behavioral therapy programs. Not every center has one of those. We happen to have one at Stanford, which is really nice that I can send patients to it. We have a women's wellness center and they'll
Right.
do a CBT program. And then because I'm in the Bay Area, there's other things that haven't necessarily been shown data-wise to be helpful,
Mm-hmm.
but maybe they will help this particular person, sort of depending where they're at. So we'll talk about like the
Right.
very limited, not really recommended, but limited data on like acupuncture and yoga and exercise and all that
Although
kind
I
of stuff.
talk to people about acupuncture all the time because I think there's basically zero harm. And if
Right,
nothing
exactly.
else, acupuncture is a form of meditation, and meditation and wellness have been shown to help with
Yes.
some of these symptoms. Um, I find the biggest, oh yes, definitely vaginal estrogen. Vaginal estrogen
Yes.
all day long.
All day, every day.
Every menopausal woman, no matter what their risk, it does not absorb systemically at any great dose. And there was
Mhm.
actually a beautiful database study out of the UK that looked at like tens of thousands of women and looked at anyone diagnosed with breast cancer was put on vaginal estrogen to see if they had an increased risk of recurrence, and they actually had a slightly decreased risk of recurrence. So I think we have good real world data that tells us that it is not causing harm. And that was across all types, treated, AI, tamoxifen, all those women. I think, so should it be okayed by MedOnc? The answer is I give my patients the data as I know it. I send my note to their med-onc and I offer to prescribe. I think a lot of med-oncs are behind the times on this data. I'm seeing more and more who are really up to date on it, and that's great. And I love that. But I tell my patients, this is the data I have for this. This is the ACOG recommendation that says that it's probably a safe thing. Here is the UK study that we have, and I think this is safe. And then we go forward
Yeah.
because, we have different perspectives, us and med-onc, right? So med-onc's goal is to reduce recurrence to the smallest possible number.
Right.
My goal is for this survivor to live and thrive.
Yes.
So both of those can be true at the same time. And, I just think patients have to learn to balance those things. And I feel comfortable that I'm not going to be causing recurrence. So,
Right.
um,
But that's a tough one, right?
one of the stickiest things I deal with, Amy, is when I have someone who, for whatever reason, estrogen or hormones are contraindicated, and they have something like the severe PMDD. And that's where I have actually managed to get approved through multiple prior authorization attempts. Things like Orilissa, So elagolix or relagolix.
Right.
So turning off the last of perimenopause with a GnRH antagonist. And it can take a little while to get it approved. But basically putting them into menopause just a little bit early. And sometimes you don't have to go all the way to menopause. The interesting thing about elagolix and relagolix, if you use it at the 150 once a day, it doesn't totally turn off the system. So it's not a complete suppression of ovulation. And I don't really understand how that works. And maybe we should do a deep dive on that. But at that lower dose, you're not getting a complete turn off. Now, if you do the 200, and it's always baffled me that the starter dose is 150 once a day, and the next step up is 200 twice a day. At 200 twice a day, you completely suppress the axis. And sometimes that's necessary. But, that's been something I've gone to probably a handful of times in the last 5 or 10 years in patients who are truly I have had some patients who are suicidal for a week and a half a month. And that's not acceptable. And we've tried OCP or they can't have it and it doesn't work. Then I have gone down this pathway.
Yep. And I've had a few where we've done a BSO, where we've because, they failed all medical management because if someone is suicidal 10 to 14 days out of the month, that's a greater risk to them. Than,
than menopause early. Yeah.
Exactly.
And the reason I've used the elagolix relagolix is that I tell my patients we can try it. If it makes it worse, you can stop.
Right, which is nice.
We just stop. I often use it as a trial run to a BSO, and they accept it much better than the Lupron, which you can't stop. Like once you're on a 1 or 3 month dose of Lupron, you're stuck with it until it wears off. So it's a great option from that perspective.
How long till those medications wear out of your system? Like, is it a pretty rapid?
Like 28 hours or something like that. Yeah, it's really quick. It's a daily dose because it has such a short half-life.
Yeah, that's great.
Yeah.
That's a pretty quick.
It just gives them the reassurance. These patients tend to be very cautious about hormones because they've suffered from hormones for a very long time. And so even something that theoretically should work, they're very cautious about. So the ability to say this isn't working and stop is very important to their sense of control. We are 10 minutes to the hour, so I am going to stop talking.
Okay.
I know. You and I could go on for hours.
Literal.
I want to make sure that anyone who wants to put a question in the chat or ask us a question even out loud can go ahead and do so. I know we covered a lot of ground today about perimenopause. I think it's a really tough time to treat because it just is so dynamic.
Yeah.
But also so different from woman to woman.
So different. There's no blueprint for it at all. And you're balancing so many things. And so that's why when you're trying to come up with a therapy option, sometimes if they have 9,000 symptoms, I'm like, let's pick the top 3 that are the most impactful to your life. And then that's how I'm going to tailor what we're doing, because it's, am I dealing with the anxiety? Am I dealing with the bleeding? Am I dealing with, what am I trying to really optimize?
So first question in the chat is abnormal bleeding on MHT, either perimenopause or postmenopause, especially if declining an IUD. Abnormal bleeding is a pain in the ass. Good luck. We have all had these patients who spot on pills, who spot on MHT. We change the progestin. So my first goal, if they're on MHT, I change the progestin. So if they're spotting on prometrium, I go up from 100 to 200. If 200 doesn't do it, I go to medroxyprogesterone acetate or I go to agestin. I just try all their progestins. Everybody responds differently to these because remember, we have different panels of progesterone receptors in our bodies. Like genetically, they're just different person to person. Sometimes you need a little more estrogen. Are they bleeding because they're too thin of a lining?
Right.
So little adjustments that you can trial. It is never appropriate to do an ablation in menopause.
Nope. That's if there's nothing else we take away from this.
Yeah,
it's
do not do that. Talk them into an IUD. Make sure you're sampling if they continue to have regular bleeding despite these manipulations, because it could be that we're just missing hyperplasia.
Right.
But it can be really hard to control. And so I have had patients go off hormones for this. And I have had patients go to hysterectomy for this.
Yes.
Because they can't go off hormones because their symptoms are so bad. Yes. So not the ideal solutions, either of those. But yeah. Oh, I'm sorry the link to the he study won't work for you. I will try to put in the chat before I leave it. I'll put the PubMed, at least the link. But if you go to Up to Date and look at, like, it's perimenopause. It's the graph in there. And then someone said,
Agestin's one of my favorite ones to use if you have somebody, if they fail Agestin, you know.
If they're close to perimenopause, Slind, as Dr. Voedisch said earlier,
Yes.
Slind is great because then you're getting like contraceptive level progestin, and that can work really well too.
That can work really well.
At the last NAMS conference, they presented estrogen suppositories safer than cream. What do I do in my practice? So the suppositories are set dose, and that's what they were talking about. So you can either use a 4 or a 10 microgram dose, whether it be Imvexxy or Vagifem. I almost never use Vagifem. I find it useless. Putting 10 micrograms of estradiol at the cervix is not going to help with sex because the sex hurts down low. So I tend to use primarily Imvexxy and estradiol cream because both of those get to the external tissues, get to the vulva, get to the posterior fourchette, get to the urethral opening, all these, and get to the clitoris. Imvexxy is a great option. It's in coconut oil. It's 4 or 10 micrograms. I always use 10 micrograms. I don't think the 4 microgram really has a use, but I feel fairly comfortable using cream. I only use 1 gram internally. Or oftentimes what I'll do is if I have a patient whose symptoms are primarily vulvar, I'll just have her put it on the outside, like a 0.5 gram on the outside, a couple times a week. Smear from clitoris to posterior. And that works great too. But yes, you can overdose with cream. And in fact, if on the little slide thing, there's 1, 2, 3, and 4 grams. I have seen endometrial development with 4 grams of estradiol cream. It does get absorbed. So if you're using that much, you should probably be using progesterone. But I typically don't use above 1 gram. They only really need 1 gram internally, and then I have them smear a little on the outside.
Yeah, no, exactly.
Yeah. All right. Oh, we'll put this link to the he study in our follow-up email. Thank you, Britt, because I was trying to figure out how I was going to find that and put it in the chat before we left. All right, everybody. Any other questions that we can answer before we sign off today? I don't see any. Anything you want to impart? Any great wisdom you want to impart before we go, Amy?
I think the main thing, like we talked about at the beginning, is just listening to your patients and validating what they're saying. I think gynecologists, primary care doctors are dismissive, but gynecologists can be really dismissive in perimenopause, unbelievably dismissive.
We all can. We all have hard days. It's the hardest appointment you're going to have on your schedule. Don't get me wrong. Even for us, sometimes when we see that on our schedule, we're like, oh, this is going to take me a solid 40 minutes to get through.
Right.
But they just need to be heard. And you're right. I think that's why there's so much predatory stuff out there, is because we as physicians and APPs have not done a great job of listening to women and their needs.
Yeah. I mean, that's sort of our general theme. Really, I just could say for this country in general. And we continued it, in our own practice. But that's just my main thing.
Yes.
It's just, and there's options.
That's what we're trying to change. Right?
Yes, exactly. And there's lots of options. And I'm just really excited to be here today. And thank you so much for having me.
I know, this was really fun. It was lovely to talk to you. Thank you, everybody. So nice to see all of you. And yes, we will send out an email on Tuesday with the recording and some follow-up information.
And we can forward that recording on to
everybody. Share widely. Yes.
Love that. Okay, that's awesome.
All right. Good to see you all. Take care. Bye-bye.